Welcome back to the MD Customer X YouTube channel. Today I am going to be discussing the best way to diagnose hypothyroidism using very basic laboratory tests. And let me tell you, it's a lot more than just your TSH. So let's jump into today's content, and if you stick around to the end of this video, I have a special bonus tip to share with you. Let's get into the information.
My lab tests are normal, but I still have symptoms. And I honestly hear that every day, every week. We fill, on average, I would say about 10 to 15 thyroid prescriptions here a day. So, 50 to 75 patients every week are coming through the door, and they're complaining to me, and any pharmacists here in general, that they still feel like crap and they have all these symptoms, and why isn't my thyroid medication working, and why do I have to keep changing the dose, and so on and so forth. And it's a vicious cycle. So hopefully we can get to the bottom of some of those things tonight and get rid of those symptoms. So take home point number one, when it comes to thyroid function, you want optimal. I'm going to talk a lot about optimal levels tonight. I don't want to have patients just be within the normal range, and that's a lot of times what happens is patients will come in with their labs, we'll sit down, we'll discuss them, and nothing's flagged from the lab. Like their TSH is fine, their T3, their T4, so on and so forth. And I always caution, I say, we're not shooting for, you still have symptoms, so something's wrong. So we're using the thyroid labs as a tool, but we need to go beyond that. So we'll look at what are some of those other things that we can look at to help, diagnose that patient and to treat that patient. So I don't want you just to settle for normal. If your provider, whomever, tells you that, oh, your labs are fine, so it must be something else, I would encourage you to dig deeper on that. There's more than this, but I tried to keep it, again, I don't want to overcomplicate anything tonight. There's T1 and T2. I'm not going to worry about that tonight. The main thing we want to worry about is T3 and T4. So I put the other names on here. So T3 is your LowThyroid. Brand name for that is Cytomel. T4, we're going to get more into details on this, but T4 is your levothyroxine, and there's a gazillion names for that. Yep, I mean, that's a generic name. Brand name is Synthroid. There's other brand names out there too. We'll touch on that down the road here. But just think in your mind, we got two hormones, T3, T4. Some functional medicine providers actually think of T4 as a prohormone. It doesn't have any activity. If you were just to feed the body T4, it really wouldn't have any thyroid function unless it gets converted into T3. We're going to look a little bit into that and why that makes sense. I'm not going to get into this entire cascade, but when we start looking from a functional medicine standpoint, there are other glands in the body that are influencing the thyroid gland, specifically the pituitary gland. That's the gland that's releasing TSH, the thyroid stimulating hormone that most traditional doctors are measuring. And so the problem with that is you're not really measuring output, which is the T3, T4. I want to be looking at what is the thyroid gland actually producing. When we're looking at TSH, we're actually looking at what the pituitary gland is producing. So, not that that's wrong, but it's, in my opinion, it's not the best tool that we have to identify, or to basically identify if there's malfunction within that particular gland. If I want to look at, we do a lot of sex hormones here for analogy. We'll do progesterone, estrogen, testosterone replacement for men and women. We're looking at that actual hormone to see if it's high or low within range. So when I'm looking at thyroid function, in my opinion, we should be looking at that same thing. What is that actual gland producing versus another gland that's influencing the gland? You can see how it gets messy right there. And you can take it up a step further. The hypothalamus releases something called TRH. So you can see where this can get. Let's just get down to the nitty-gritty, get to the root cause of the thyroid issue, and look at that. So we'll get more into TSH here in just a minute. So always remember two things about your thyroid labs. Your T3 activates, so that's important. So we'll get to a slide on that in a minute. And then the other thing I want everyone to take home tonight, my TSH fabricates, meaning it's deceitful intent. It's showing the patient that, oh, if that TSH is within the normal range, I should be fine. But really what we'll see in a minute is the TSH is just, it's correlated, but correlation doesn't equal causation. This picture's a little busy. I was going to leave this one out, but the take-home point on this particular slide, so this is a really simplistic picture of every cell in your body, indicated by the black line. You've got a nucleus in every cell that has all the DNA. When this T3 hormone gets transported inside the nucleus, a protein is made. There's only a receptor on our DNA inside the nucleus for T3. There's not a T4 receptor. So there's a lot of things that have to happen for the T3 to actually have activity in the body. And so your TSH could be perfectly fine. It could be spot on. I like to see a TSH between 1 and 1.5 if I had my ideal range in my mind. And that patient could sit down and they can have that TSH of 1.2. Sounds beautiful. But they feel like crap. And there's a lot of steps involved of getting that T3 inside of that nucleus that can go wrong. So back to TSH. Why is the TSH test problematic? So thyroid stimulating hormone reference range for normal is a huge net. It's between 0.5 and 4.5 if you look at it from a traditional standpoint. That encompasses, in my mind, too many patients that are in the quote-unquote normal range. The new normal range by the American College of Clinical Endocrinologists, I can't remember, this was back in 2012, this is already 10 years ago, they shortened that range up a little bit to 0.3 to 3. I still don't think that's good enough. We're still missing patients that have a sluggish thyroid hormone. And if we're just looking at TSH, again, there's too many patients that we're missing even if they fall within that range. You could have a patient that has a TSH of 2.5, and if that's all you're looking at, that patient still could have hypothyroidism in my book. Thyroid dysfunction is much more common. I touched on this in my mind in other books that I've read from Dr. David Brownstein, pharmacist that I follow, Isabella Wentz as well. That number could be up to 40% of the population could have hypothyroidism, not 12. So that includes a lot more patients. So thyroid dysfunction is a much more common health issue than we might see reported. It's overly inclusive in that general population. That TSH range is just way too wide. And again, I touched on this. TSH is a pituitary hormone. It's not a thyroid hormone. I want to look at what that gland is actually doing. So the functional approach to diagnosing hypothyroidism. I want a complete thyroid panel. We'll look at that in a minute with other endocrine testing. So not just the thyroid gland, but I want to look at adrenal function as well. Medical history, basal body temperature, and also even a physical exam. So we're looking at the whole patient. We're not just isolating out their thyroid gland. I lost my heading here, but these are the labs that I want to see for every single patient. So on your handout, you're going to have all of these labs. So when you go to the doctor, I encourage you to take that and get as many of those boxes filled out as you can. The more information we have on this, the better to help get the right treatment for that particular patient. So TSH, your total T3, and your free T3. So the difference between that, so when thyroid hormone is made, and this is important to understand, is that there's a lot of binding proteins. There's albumin, there's specific thyroid binding protein in the blood. If your T3 and your T4 are bound up to any protein in the blood, it has zero effect from a physiological standpoint on creating a benefit to your body. It's tied up, it can't be used. So if you look at just the total amount of T3 and T4, again, that provider, you as the patient, we're not getting a clear picture of what's going on in the body. So you could have, again, normal levels of total T3 and total T4, and they're really not, they are of value, don't get me wrong, but we want to look at free fraction. We want to look at what is the unbound portion of your T3, what is the unbound portion of your T4 in your blood, and we can measure that. We have a ZRT test kit that we use for patients all the time that you can measure the unbound portion of thyroid hormone. That to me is valuable. test to have. So patients have come up to me and says, well, my doctor doesn't do total T4. The lab doesn't do it. I'd rather you have just the free T3 and the free T4 and the TSH. Give me those three numbers if I had to pick three. Again, we're not going to get into the antibody discussion with Hashimoto's tonight, but I do, with the ZRT kit that we do measure antibodies, the TPO level, so we want to rule that out, but we still should have that measured. 4-point cortisol. I get this question a lot. Well, my doctor just did a blood test and they did the cortisol test in the morning through the blood stick. In my opinion, that's highly inaccurate. It doesn't give you the full picture again. Just poking your arm with a needle can raise your cortisol and give a false impression that that patient's cortisol is high. So we like to do a salivary, or basically a spit test, that you measure the cortisol throughout the day, and that's going to be a better indicator if that patient has poor adrenal function or not. So that's what that 4-point test means. It just means you're testing the cortisol at 4 different times throughout the day, but using saliva. I probably should have put that on my slide, sorry. DHEA, sex hormones, I'm not going to get too much into that tonight, but I do want to look at the patient's hormone levels, especially progesterone in women, influences conversion of T4 into T3. So if that woman's progesterone is low, that could be the reason why they're not converting T4 into T3. So that could be something that's missed. Urinary iodine, we'll talk a little bit more about iodine later on when we get into supplements, but I'm a big fan of looking at iodine levels. If you don't have the right building blocks for T3 and T4, and iodine is one of them, then we're not going to make enough thyroid hormone. That could be your issue. Selenium, it's a good antioxidant. Magnesium, we'll talk more about that. Vitamin D, and then iron and ferritin. So if we can get all of those labs, that just gives me as the pharmacist a very clear picture of what might be going on. I've had patients where their ferritin, I'm getting ahead of myself, I'm sorry, this happens a lot. You've been here before. But with the ferritin being very low, we've had patients just bump up their iron levels and their thyroid hormone production improves just by giving them iron and ferritin.
If you made it this far in the video, thank you. For my bonus tip, I want to share with you 3 simple steps to get a proper thyroid diagnosis. Number 1, have your provider perform a medical history. Number 2, start taking your basal body temperature at home. And number 3, have your provider perform a physical exam. All 3 of these steps sound simple enough, but often they are overlooked. In my future video, I am going to be discussing the functional approach on how to properly diagnose thyroid disorders. If you found value in today's video, I encourage you to like this video. And if you know somebody that's struggling with hypothyroidism, I encourage you to share this video. Thank you for tuning in.